Kia ora tātou, everybody. Bruce Arrell's my name. I'm the director of the Goodfellow Unit. And tonight we have Jenny Casale. She's a New Zealand registered dietitian and has worked in gastroenterology before. Her topic tonight is how we talk about weight and bodies and why this matters. Her PhD was on nutrition in Maori and Pacific infants, and she currently works at Massey University. So Maria, over to you.
Thank you for that lovely introduction. Yes, as Bruce mentioned, my name is Maria, and I'm really excited to be talking to you all tonight about how we talk about weight and bodies and why that matters. And really hopefully get you all thinking about why weight is an easy go-to point for many healthcare professionals and why that can be really problematic. I guess I just want to mention one thing. So I will be using the word fat a lot tonight when I refer to people with larger bodies. That's a word that has been reclaimed by the fat positive community. So just a heads up about that. This is just a brief overview of the slides. So first I'm going to give you a little bit of context and background for HAES, which means health at every size, and the non-diet approach, and a little bit of an overview of the evidence around that. Then we're going to go into how we talk about weight and bodies, cultural considerations and impacts. I've got a very mini case study example as well to kind of try and demonstrate how that works, which is more from a dietetic perspective, but hopefully will be helpful for everyone to see. And then of course we have questions at the end. As healthcare professionals, we are of course primarily concerned with the health and well-being of our patients, and the health at every size paradigm offers an alternative to weight-centric approach. This is where health is not defined simply as the absence of physical or mental illness, rather that health exists on a continuum, and a continuum that varies with time and circumstance for everyone and is very unique in that regard. I think as well, ideally, health should be thought of as a resource or a capacity that's available to everyone, regardless of any health conditions they have or ability level, rather than an objective or outcome of living. Pursuing health, of course, should never be a moral imperative, nor an individual obligation. Health status should never be used to judge or oppress or determine the value or worth of an individual. So the health at every size paradigm promotes health equity, it supports ending weight discrimination, and it's about improving access to really good quality healthcare regardless of a person's shape and size. This is particularly important because weight stigmatization and discrimination actually remains one of the last widely accepted forms of discrimination. What I would say is if you do happen to exist in a small size body, as we go through the next few slides, I just invite you to really think about what it might feel to exist in today's society in a larger body. Also just popped a link there if anyone's interested for the Association for Size Diversity in Health. What I'd like to invite you all to do for a moment is think about how it would feel or how your life would be if we waved a magic wand and all of a sudden you weighed 50 kilos more than you do now. So I'm not going to spend long on this, but I just encourage you to think about how your life would be in terms of your body, your health, your relationships, your job, your work situation, your social life, and just your activities of daily living. And we will come back to this later on. So just bear that in mind as we go through the next few slides. Let's talk about the principles of HAES, or health at every size. So weight inclusivity, that means or refers to quality healthcare that can and should be available to everyone, as I mentioned before, regardless of their size, regardless of their shape, and regardless of why they are any given size. So this is something that really disproportionately affects fat people. Most healthcare professionals believe that fat people become fat through neglect of their health, that they're lazy, that they are non-compliant to health recommendations, and that in turn results in avoidance of healthcare, and that's due to the shame and stigma associated with that. And then also in turn poor quality of care when fat people do seek care, as weight can be focused on in lieu of the actual problem. So all of those principles of HAES sort of aim to address that. So let's talk about a little bit of evidence around HAES. So we know undoubtedly that the pursuit of intentional weight loss with various dietary and lifestyle modifications, it absolutely reliably induces weight loss in the short term, no doubt about it. However, long-term weight loss is unsuccessful in most people, and the pursuit of this has unintended consequences, and those consequences are quite wide-ranging. So that can be food and body preoccupation, repeated weight cycling, which has a lot of harms of its own, distraction from personal health goals and wider health determinants, reduced self-esteem, disordered eatings and eating disorders, and of course weight stigmatization and discrimination. So how sure are we that weight regain, happens after intentional weight loss most of the time? There's pretty strong evidence. So efforts to make fat people thin fail over and over. We have decades of research on diets and lifestyle changes that show that while people can intentionally lose weight for maybe 6 months to a year, an estimated 95 to 98% of people eventually regain most, all, or even more of the weight they initially lost. You really just have to look around to see that intentional weight loss has an extraordinarily low success rate. And not many people would choose to be fat, given the society-sanctioned stigma that most fat people face in all facets of their life. Yet the rate at which weight loss is prescribed is alarming. So imagine for a moment there was a new drug for epilepsy. And imagine that that drug had the same rate of success as long-term intentional weight loss. Then imagine that that drug was prescribed as often as weight loss. So building on that, this kind of thin-centric healthcare where weight loss is prescribed so often can cause great harm to our patients. So there is a study that showed fat women who intentionally lost at least 15% of their body weight were over 2 times higher risk of death compared to fat women who remained weight stable. Another study found that the risk of dying from cardiovascular disease was higher in people who lost weight, and that risk increased proportionately with the amount of weight lost. So in the Park study that I've got up here on the screen, they found that the group that lost over 10 kg were 3.5 times higher risk of dying from cardiovascular disease compared to the weight stable group. Yet, despite this kind of evidence, many healthcare providers do still encourage weight loss for all fat patients. Unfortunately, some healthcare providers even refuse to offer care like medication, referrals to physiotherapy, or may even deny surgery. In fact, definitely even deny surgery unless patients pursue and attain weight loss, and quite often a significant amount of weight loss. It has also been suggested that this kind of approach to healthcare may account for the health disparities seen in fat people, much more so than body size. Okay, so we're probably all quite familiar with the set point theory, and the greatest predictor of future weight gain is the pursuit of intentional weight loss. So essentially, this theory proposes that our bodies have this established, biologically regulated set point weight range, and our bodies work incredibly hard to return to the set point after weight loss. However, that set point can gradually increase as more weight is regained, and that is one of several factors that make long-term weight loss so difficult to sustain. So there's really strong cultural and societal messages about bodies being good, bad, acceptable, attractive, that our bodies are something to be controlled or fixed, that we can and should be spending a lot of time, energy, and resources on our bodies and appearances. Larger bodies generally are regarded with disdain, smaller bodies with admiration, as long as they're not too small. It's commonly believed that weight equals health. It's sort of a societal belief. And it's often automatically assumed in wider society that a lower body weight means better health automatically, whereas higher body weight suggests poorer health. Appearance over function as well. Absolutely, society does tend to prioritize the appearance of the body over the functionality. Often lean muscle mass is lost during weight loss attempts, and there's significant effects on bone density and immune function, just to name a couple. In terms of the perfect body being achievable, this is something that comes at us from all angles. So it's not just print and television media that portray this thin ideal and promote this perfect diet to gain the perfect body. Social media and influencers on social media play a huge role in this, particularly for our vulnerable teenagers and younger adults. It's not uncommon to see influencers doing a little piece where they say what I eat in a day. And it's really difficult, because if we all ate exactly the same thing and exercised in exactly the same way, we would still look very different to each other. And of course, that's all about genetics. Gendered body expectations. So there's societal expectations around masculine and feminine ideals, and this helps contribute to body dissatisfaction and gender-related body image issues. And then there's the thin ideal. So that's that prevailing beauty standard. And that, of course, changes with time, but the thin ideal is just an overwhelmingly consistent feature of most beauty standards around the world. Not all, of course. Health moralization occurs when people's health is morally judged based on their appearance, and assumptions are made about their lifestyle, their eating, their habits, and then age-related body expectations. Really tricky. There's specific expectations and standards for bodies at different ages. So, for example, a woman's body would change profoundly during menopause. The shape will change, not necessarily the size, maybe that as well. Yet so many women feel this intense pressure to maintain their premenopausal body shape. So this really matters. I mean, this is having a profound impact, and really frighteningly so, on children. So children getting a sense of body image by the age of 3. By 6, girls expressing a desire to be thin, increased weight concern at ages 5 and 7, and clinical eating disorders being diagnosed by age 9. And I would hazard a guess even younger, since that has been published. So what is the issue if you focus on your patient's body or size? So it upholds those body ideals that we were just talking about. It perpetuates those narratives about bodies. Weight becomes a distraction from what the real health problem is, and it reinforces weight as the problem. It directs health services, and then bias in treatment is not examined, it's not addressed. And that leads to internalized weight stigma. So for the patient, how that presents is self-judgment, really negative evaluation, and then that leads on to body shame, and then that results in impact on psychological and physical well-being. And that is a problem, because then we start looking at the cycle of shame in healthcare seeking. So people experience body shame. They avoid presenting for healthcare because they're worried that they're just going to be told that they must lose weight or go on another diet. And that results in the exacerbation of their health issues. So eventually they will present, and then that is blamed on their weight. Weight loss attempts then usually inevitably fail, and that perpetuates that body narrative. And so the cycle starts all over again. The consequences of this, as I've just mentioned, patients are less likely to present for healthcare and have incomplete recovery as well. But the consequences for us as healthcare professionals is that we don't have to confront our own biases. It maintains the status quo of cultural ideals, and it also maintains that so-called ideal picture of recovery as well. So what we think about our patients' bodies, a study, this was a study by Poole, and it was really interesting. So this study was done amongst eating disorder professionals, and the aim of the study was to identify to what extent their biases were associated with attitudes about treating larger patients. There were 330, I think, eating disorder professionals recruited into this, and 88% felt confident treating patients with large bodies. 84% were prepared to provide treatment to larger body patients, which is awfully good of them. 56% had observed other professionals in their field making negative comments about larger bodies, and 42% felt that in general, ED practitioners, eating disorder practitioners, hold negative stereotypes about larger bodies. What a particularly concerning finding in this study was that 35% stated that they felt uncomfortable caring for people with larger bodies. This is in the eating disorder field. So there's been quite a recent study done by a student dietitian at the University of Auckland, and she wanted to explore the prevalence of weight bias amongst New Zealand registered dietitians and how that impacted on their practice. So the way this worked is that the dietitians who took part, there were just over 100, I think, they were randomized to receive a case study for a condition unrelated to weight, which was lactose intolerance. And that case study was accompanied by a photograph, as you see here on the screen, of a woman, either in a smaller body or a larger body. Now, this was done on purpose to keep everything as similar as possible. So it's a black and white photo. They're both looking directly at the camera. They're both smiling. They're both wearing similar clothes. The participants were then asked to assess the client based on the data provided and provide recommendations and rate their perception of the patient. So the dietitians assessed the larger mock patient to have lower health and were more likely to provide unsolicited weight management advice. The larger patient was also rated as being less receptive and less motivated, and also less likely to understand the recommendations and a lower ability to comply with and maintain the recommendations. And just to reiterate, these were identical case studies other than the photos that you see before you. So body image issues come from the burden of comparison, and that comes from assumptions about weight, fitness, health, Fitspo sports, fashion advertising, which reinforces slim and muscular figures, doctors, coaches, sports codes imposing weight standards, fitness and diet culture assuming rigid diets are better or somehow magical. And just by existing in the room with your patient, you are naturally inviting comparison. And that's particularly so if you have overlapping, like membership and overlapping sociocultural groups. So for example, age, gender, ethnicity, or education, or other factors. But it's an opportunity to discuss with your patient how this is not an accurate way to gauge health, performance, participation. It helps reframe their expectation and loosen their internalized weight bias as well. It's a step towards that at least. And that can be in turn a step towards maybe helping improve their body dissatisfaction. And I completely understand that, particularly as GPs, you don't have time to be spending on this in a short appointment, but just a comment here and there even. So my GP, for example, does this really beautifully, and she will just make a comment naturally like, oh, I struggle a bit with this too. And it might not seem like much, and it might just seem like a passing comment, but it actually goes a really long way to sort of breaking down that temptation to really compare and judge yourself. So in New Zealand, in Aotearoa, the greatest predictor of poor health outcomes is ethnicity. So Māori and Pacifica bear a 2 to 4-fold burden of diabetes compared to New Zealand European. And they're also almost 3 times as likely to experience renal failure as a complication of that diabetes. There's increasing prevalence of cardiometabolic conditions amongst Māori and Pacifica. Interestingly as well, this is from quite a recent study, the rate of dispensing antibiotics for Māori and Pacifica people differ very little from the rate of dispensing for other ethnic groups, despite Māori and Pacifica having a significantly higher incidence of many infectious diseases. And look, there could be lots of different reasons for that. For example, not presenting the script at a pharmacy. Yeah, it can be explored more, but the fact is, that is what has happened. There's rising inequalities in rates of rheumatic fever, acute rheumatic fever, and rheumatic heart disease, and the hospitalizations and deaths for Māori and Pacifica due to that are much, much greater. There's also quite significant disparities in the prevalence of like chronic pulmonary conditions, liver, renal disease, that really exacerbate the impact of COVID-19 as well. So why is this? The absolutely substantial inequities faced by Māori and Pacifica have been created and perpetuated by the social determinants of health, and that includes institutionalized racism. There's differential access to timely and quality health care for lots of different reasons. It relates in delayed treatment, delayed diagnosis. There's intergenerational transmission of social and economic determinants of health, and of course, weight discrimination. So this quote here is from a quantitative systematic review that was interested in investigating the associations between weight stigma and physiological and psychological health of people with larger bodies. I thought this was a particularly interesting finding, particularly in light of diabetes, or the disproportionate burden of diabetes that Pacifica and Māori people bear. But some other findings from that study was the most common measure for weight stigma was frequency of experiencing weight stigma, followed by internalized weight stigma, implicit and explicit weight bias. The greater the weight stigma, the worse the physiological health status of overweight and obese adults. Not words I like to use, but for the sake of this I am. Regardless of the measures of weight stigma. And the greater the weight stigma, the greater the eating disturbances, depressive symptoms, anxiety, body image dissatisfaction, and the lower the self-esteem of larger adults. So these are some of the reasons why it really matters what you think of your patients' bodies. So coming back to the question I asked you at the start of the talk, so thinking about what your life would be like if all of a sudden you weighed 50 kilos more than you do now. And it's a really interesting activity to do with people. Obviously, we are not interactive here, but typically people find it very, very easy to fill the worst column with all the things that would be much, much worse about their lives. The same column, reasonably easy to fill, but people really struggle to think about what would be in the better column. Now, the point of this exercise is to help you identify any internalized weight bias that you may hold. And look, everyone has some, and that's okay. I think the important thing is that how you recognize it and deal with it. So when we hold internalized bias, it's also likely that you may be consciously or unconsciously projecting that onto your patients, and indeed maybe yourself as well. So what can we do as healthcare professionals? How can we talk to our patients? So this is probably something everyone's quite familiar with. So person first language. Again, these are not words I like to use at all, but for the sake of this exercise, I'm doing so. I guess just as a brief explanation, fat people find the word obese or overweight really offensive. It's just, yeah, it's not okay to use with them. So person first language. So rather than obese person, it would be person with obesity. Whereas if you had a non-judgmental language, you could argue instead of person with obesity, you would use person in a larger body or a fat person, and that would work too. But also we're just human beings. We don't necessarily need to define ourselves or our patients as such. So some ways that you can address body shame without focusing on weight loss. So tell your patient your body is not a problem. It is not your fault. That it's such a powerful, validating thing to say to someone, especially someone who has dealt with stigmatization because of the size of their body, possibly even for decades. Addressing their health concerns in a weight neutral way, really thinking about what is the actual cause, what's really going on here without thinking about their weight. As we've just talked about, recognizing and understanding your own biases, that will help with not subconsciously passing them on. Acknowledging, respecting, embracing size diversity, and knowing how to really advocate for your patients. So I have a quote here, and this is, "I dread seeing a new medical professional because I'm afraid they're going to judge me, talk about obesity, not treat me for my actual health condition, give me the wrong treatment because I'm fat, not listen to me, or flat out be mean to me." A pretty powerful statement. Okay, so what I'm going to do now is talk about a mini case study. I've chosen a pretty simple one just for the sake of not necessarily wanting it to go into a huge amount of detail. And this is, of course, very much from a dietetic perspective, but hopefully you'll gain something from this. And the idea of this is to hopefully give you some insight into how a non-diet dietitian works and what our approach would be like. So this is Mrs. H, a 53-year-old who was seeing a gastroenterologist and was referred by them for nutritional support with non-alcoholic fatty liver disease and pre-diabetes. And she was told by the gastroenterologist that she must lose at least 15% of her body weight over the next 6 months, which coincidentally is the diagnostic criteria for malnutrition. So Mrs. H works part-time in a sedentary job as a legal secretary, lives at home with her husband and teenage son, and at her initial appointment, her weight was 95.5 kilos, and that was provided in the referral. And normally, when you're doing the non-diet approach, you wouldn't be focusing on weight, but again, for the purpose of this, I've included it. And you can see her biochemistry there. High cholesterol levels as well. Blood pressure not ideal, but bowels fine, opening once a day. She doesn't want any medication. She really wants to try and manage everything through diet. And that's something we hear really, really commonly as well. People definitely seem to associate a lot of blame and shame around things like high cholesterol, pre-diabetes, fatty liver. They really, there's so much stigma attached to it, and so often we hear, "I don't want medication, I just want to try and manage this with my diet," and then they often embark on some quite strict, extreme dieting practices as a result. And this is definitely how this lady was thinking as well. So I don't want to bore you with the details of her diet. I actually think it's very interesting, but suffice to say, her energy intake was adequate. There wasn't too much. It wasn't inadequate, but she did have a high saturated fat intake. She did have quite a high sugar intake, moderate to low alcohol intake. It seemed to vary from week to week. Very low intake of fruit, vegetables, and whole grains as well, which resulted in a low fiber diet. Adequate fluid, but some of that did come from orange juice. She also described episodes of subjective and objective binge eating, so 1 to 2 times per week with no compensatory behaviours, and described essentially having been on a diet since she was 10. In fact, she said, all my life I've just known that I was too big, and that was a strong message from her parents, with her mother taking her to her first Weight Watchers meeting when she was 10 years old. And of course that's going to have a profound effect on a person over their lifetime, coupled with everything else we've talked about, the expectations. In regards to that binge eating, again, it's really common to see when we do see this kind of presentation as a dietitian. I think eating disorders are far more widespread than what we know, but I guess that's also my subjective view on it as well. So we talked about some interventions. So bearing in mind, again, she was really keen to focus on her dietary intake. So we just talked about some really simple things. And the goal with doing this was not about taking anything away. It was about trying not to replace things, but just adding new things in. And this is, I think, quite a core part of the non-diet approach. So we're not trying to deprive people, because that can lead to binging, it can lead to disordered eating and take you down quite a dangerous path in that regard. So it's just about introducing new healthy habits that will hopefully start to displace maybe less helpful habits over time. So for her, it was very simple, just a couple of serves of fruit a day spread across the day, introducing whole grain bread because she was having white bread, aiming to introduce at least half a plate of non-starchy vegetables, both at lunch and at dinner, and that could look any way she wanted it to look in terms of cooking, etc. Introducing additional water at the same time as each juice drink. So again, it's not taking away the juice, because we really didn't want her to feel deprived, but just adding in additional water. And we reviewed a behaviour chain for a specific recent binge that she had had, and reflected on what the triggers were that led up to that binge. Then we talked about a couple of particular intuitive eating principles. Now, intuitive eating is a whole framework that's made up of 10 different principles, but the two ones we specifically focused on were honouring your hunger, and that's about keeping your body really well fed with enough energy, enough carbohydrate, enough protein. Otherwise, if you don't, you can really trigger that primal drive to overeat, and that was what was actually triggering most of her binges. Once you sort of reach that moment of excessive hunger, all your intentions for being moderate or conscious or mindful eating, it's really hard to hang on to that. The other intuitive eating principle we looked at was discovering the satisfaction factor, and it's quite a tricky one, and it can be one that can be hard for people to get their head around, but certainly that was something she was really keen to try. And it's about eating what you really want in the moment. So rather than having a set meal plan or I must eat this at this time, it's really thinking about what your body really wants. So for example, it's a freezing cold night tonight. Imagine you go out and you get caught in the rain, and you come in and you're soaking wet and you're tired and it's been a long day. You're not going to really want to eat a salad, but a beautiful vegetable soup and some hot toast might just hit the spot. So it's about thinking what your body really wants and needs. So we had a follow-up 3 months later, and what I guess I want to impress about this case study is this patient, she was really, really fearful about seeing a dietitian. She told me, I thought I was going to be put on yet another diet and told off for eating the wrong thing. And that comes back to that blame and stigma that's often attached to things like diabetes, high blood pressure, high cholesterol, fatty liver, etc. She really did blame herself for her fatty liver as well and her pre-diabetes, and she had expressed a lot of shame and self-loathing. But when she came to her follow-up, she was just a whole different person. It was remarkable. So her GP had ordered repeat blood tests a couple of days prior, and called her with the good news, as you can see there on your screen. And she said it was just the first positive interaction that she had had with her doctor in many years. And she just felt really empowered and validated for the first time ever with regard to her health. This is a very simple linear journey that I've demonstrated here, though, and this is not the norm. This is probably more of the exception, as I'm sure you can appreciate. So it's hard for people to process and unlearn years or decades of diet culture, dieting behavior, self-loathing, shame around their body, particularly when it's still being reinforced by other healthcare professionals, and particularly if it's been impressed upon them since childhood as well. So this is probably one of the more straightforward examples that I've seen, and often people sort of have, it's like the stages of change model. People have a relapse and they step forward, and yeah, it's a whole process. But look, what I'd like to ask you, and a question for you to keep in mind when you're seeing patients who are fat, what are you trying to achieve when you suggest that a fat person loses weight? So do you want them to reduce their HbA1c? Do you want them to relieve weight on a painful joint? Are you worried about their blood pressure? Are you concerned about their high cholesterol? Are they at risk for cardiovascular disease? But then also, given the likelihood of them sustaining long-term weight loss being so incredibly low, and the potential physiological and psychological damage that can do, just consider what else could you possibly offer. So we're just going to finish up with a quote, which I think is a beautiful quote, and it's, "The best gift you are ever going to give someone is the permission to feel safe in their own skin, to feel worthy, and to feel they're enough." Thank you.
So we've got some questions here. The first one is, infertility guidelines refuse individuals with BMI greater than 33 on the public query private list. What's your view of that?
Thank you for bringing that up. I'm really well aware of that. It's incredibly frustrating and disappointing. What happens is that when someone is struggling with infertility, that desire and want to have that longed for baby is just so profound, and people will do anything. So they will happily go on a diet. They will do what they need to do to get their BMI below 32, so they are qualifying for that publicly funded IVF treatment. But there's research to show that intentional or weight loss prior to conception actually has quite poor outcomes for the baby and for the mother, and it actually increases the likelihood of both gestational diabetes and type 2 diabetes for the child when they become an adult and older eventually. I think it's problematic. I understand there's greater risks associated with a higher weight in pregnancy. Again, there you've got that risk for gestational diabetes. But yeah, it's a tough one. I don't like it.
How much of it is like, is it an evidence-based thing of efficacy? You're much less likely to get pregnant if your BMI is over 33 than under 33. Is that where they're coming from, or
no? That's debatable. Yeah, so there's been quite a lot of new research over the last few years. It will depend. So if you've got someone with, say, polycystic ovaries, and there could be that interaction there, yes, that could absolutely be impacting their fertility and also their chances of succeeding with IUI or IVF. But I think you have to come back to what is the other impacts of seeking that intentional weight loss. Particularly, quite often it's quite a lot of weight loss in quite a short period of time, and then they need to sustain that weight loss until such time as their name comes up on the public list, and that can be up to 18 months. And given what a low proportion of people are actually able to sustain weight loss that long, there's a problem there. So if there was a better way of focusing on it, if there could be a focus on really, really strong dietary interventions, lifestyle things around exercise, without sort of focusing heavily on that weight, it takes the pressure off. Because I think everyone knows, I've heard the story time and again from patients who have been on various weight loss journeys where they do everything right, so to speak. So they go to the gym, they're exercising every day, they're eating everything that they should be eating, but they've increased in 300 grams, and they think, oh, well, I'll throw it all out the window. This isn't working, because there's natural fluctuations. So yeah, with the whole fertility thing, you really are caught between a rock and a hard place, and it's really hard.
So we've got some more questions on how do we quickly get past diet and move on to discussing lifestyle tips? So what would you, how do you do that?
Yes, well, this is the problem, is that particularly as a GP, you have such little time to be able to spend with your patient and try and address everything that you need to address in the 15 minutes or so that you've got. My short answer would be to ideally refer to a dietitian or a nutritionist, a registered nutritionist. I can't speak for all of the different DHB areas around the country, but certainly for Waitemata DHB, you can refer into the outpatient service if you are a GP. But it's really tricky. There's also health coaches available that are fantastic to help people with goal setting. They know about how to refer on as well. But you really can't do it justice in the time that you have available, and that's a really tricky thing.
Okay, so how do you feel around navigating conversations when requests come up re weight loss medications? And we get this all the time. You know, I want some more Duramine, and you know the weight's plateaued out basically, and you know when they stop it, it's going to go back up again.
That's exactly right, and that's the problem with weight loss medications. That there's some really mixed evidence around them, and again, it's facilitating something. Is it sustainable long term? If they come off the medication and they regain weight, should they even be on it in the first place? But it is really hard, because I get the point of that question is, how do you navigate that conversation? What do you do? And again, my answer would be refer on if possible. And I'm aware that might be a frustrating answer to hear as well, because firstly, we really care about our patients and we want to be able to help them in the moment, especially if they're distressed. And someone who's lost a lot of weight and then is starting to regain, they are going to be distressed for sure, especially if they sense a medication that has previously helped them is being withheld. And my understanding, I could be wrong, but my understanding is it's not safe to be on weight loss medication long term. I've seen, though, a number of patients on long-term Duramine in particular. In an ideal world, you would be referring them to a health coach or a registered nutritionist or a dietitian for some good assistance. And again, there's different ways to access more affordable care as well. So for example, there's student-led clinics at the universities, which are much, much cheaper. There's, like I say, I'm not sure about other DHBs, but certainly Waitemata, and it sounds like counties as well, there's that possibility to refer in. There's also PHO dietitians. There's dietitians that are available via ProCare with 5 free appointments as well. So I just really encourage those referrals and working out all the different options of where you can refer to get some help for people.
Okay, so question, what's your opinion on the rate of gastric bypass, or I guess even just the role of gastric bypass? Because my impression is about 60% of people it seems to be effective before, but there's about 40% who go right back, if not they're worse than they were when they had it.
A great question again. So it's about 50% of people it fails in, for want of a better word, but it really does fail. I think you could argue the success of the other 50% as well. I mean, my real opinion is that butchering your body through surgery in order to shrink it is not the answer. I don't like it. I don't agree with it, but that is my personal opinion. There is, yeah, it is about a 50% success rate last time I checked the statistics on it. What I used to see when I worked in outpatients at Waitemata is people sort of a few years out from bariatric surgery where it hadn't worked, and they would end up in the complications that can come from it, and it's irreversible, are really profound, and people can be affected so badly. And things like gagging on any solid food, like having that really sensitive gag reflex, but your ability to eat normally has been taken from you. In other cases, it just doesn't seem to have that effect at all, where people appear to, after a period of time, continue just to eat normally as if they had never had the surgery in the first place as well. And again, if the underlying factors were being addressed in a really sort of body positive, weight neutral way, you could argue that you might not need it.
Do you take waist measure into account? This is this person's preferred measure. What do you do for waist circumference? And is that the preferred measure?
So I don't use physical measures at all. So I like with the case study I demonstrated, I like the measure that she went from the pre-diabetes range for HbA1c to the non-diabetic range for her HbA1c. Her liver function normalized, her cholesterol normalized. That's the kind of measures that I like. So I don't use waist circumference. I don't use any kind of physical measurement of the body.
Wondering how you assess malnutrition in people with larger bodies without checking weight semi-regularly.
Yeah, so you do need to. So malnutrition is a different story again. It's a really good point, and malnutrition is wildly underdiagnosed in fat people. So the thing I would hear time and time again in the hospitals, oh, they've got plenty of meat on their bones, they'll be fine, or they've got a good buffer. It's just not how it works with malnutrition. But yes, so with malnutrition, you do need to weigh people, and I'm very clear about why I'm doing it. I'd offer the opportunity to have a blind weight, but yes, that does need to happen when assessing malnutrition for sure. You can't do it.
When might you suspect malnutrition in a patient?
It would depend on what they were in for. Like, for example, if you've got someone who is having chemotherapy, or if you've got someone who's, like, the first thing that springs to my mind is head and neck cancer, where they might have been really profoundly affected in terms of how well they're able to eat, swallow, depending on surgery, radiotherapy. Regardless of their body size, chances are they're going to be malnourished. So it really depends on what they're there for and what else is going on.
What do you think of the NOOM approach for weight loss?
So NOOM is just a diet wrapped up in some fancy psychological talk. NOOM requires you to weigh yourself. It asks for your weight when you download and install the app. They've just tried to co-opt HAES and the non-diet approach, but it is still very much a diet.
If someone has OA of their knee, is taking maximal medication, keeping active and not eligible for surgery, might we be obliged to discuss weight loss as an option, including the low likelihood of long-term maintenance?
I think it's a really good question. That's something that comes up a lot when we talk about this approach. So the first question I would ask you is, what would you do if that patient's BMI was 22, for example? What approaches? Because you wouldn't be asking them to lose weight, right? Would you be thinking about physiotherapy to maybe try and build up the muscle around that joint? I know there's lots of different reasons why people aren't eligible for surgery, but it's not super uncommon for that reason to be that the surgeon just doesn't want to operate on a person until they've lost weight, in which case I would say maybe they need, given how many people there are in large bodies, they maybe just need to get a bit better at what they do. But yeah, just to be really plain about it. But yeah, I would be exploring other options. So thinking, what would I do if this patient had a BMI of 22? How would I approach the situation if it wasn't safe for them to lose weight? And then also, I think it's still important to acknowledge they have a larger body. You don't want to kind of dismiss that fact, but also thinking to yourself, when is the likelihood of them sustaining that weight loss to take the pressure off that poor knee is so incredibly low? Is that really the best option when you consider the other harms that can occur as well? That's a tough question though. Is a really, yeah.
What sort of narratives would you use to say to somebody, you know, I notice you have a larger body. How would you suggest we raise that issue?
I would be very much guided by the patient and how they talk about themselves. And they will, if they want to. If they don't reference their body size, if they don't talk about that, I wouldn't be inclined to bring it up. I would just be very much guided by how they talk about it.
There was a question there about using the word fat. I'm just trying to remember.
Yeah.
Okay, can you explain how we've returned to the word fat? Thanks, Bruce.
Yes, absolutely. So briefly mentioned at the start of the talk. So there is this whole sort of, in the health at every size world, the non-diet world, the word fat has been reclaimed as a neutral descriptor of body size. So fat is something that has traditionally been used as an insult, and still is by a lot of people. And they're trying to reclaim that and make it not an insult, because imagine having your body size being used to insult other people who may not even be fat. It's pretty awful, but yeah, essentially it's been reclaimed as a neutral descriptor of body size.
What is your opinion about the ketogenic diet?
I don't agree with the ketogenic diet. I think there's issues with fiber and B vitamins in terms of from a nutritional perspective. From a sustainability or just life perspective, I don't think it's realistic to completely cut out certain foods. There's several micronutrients you'd be at risk of being deficient in unless you're able to be really, really careful with what you do and probably spend quite a bit of money as well. I don't think it's necessary to be healthy to have a ketogenic diet though.
Okay, so what are your thoughts on BMI, and could you share when the most appropriate opportunities you use it to discuss it with people? You might have covered that sort of in your comments.
I don't think I did really cover it, but I think BMI is an outdated racist tool that we shouldn't be using. However, it is part of the criteria for malnutrition. So BMI was developed, I think, in the 1920s using a small cohort of white European men who were in the military, I think. Hopefully I've got all that exact detail right. So it's not an appropriate measure to be used in any other ethnicity. And indeed, it used to be that there used to be higher BMI cutoffs for Pacifica and Māori, and that's actually been changed back again. But I don't think it should be used at all. Having said that, it is used for malnutrition.
So just try and get. I work in a school clinic as a nurse. Lots of students ask about their weight. Do you have any tips on helping them make changes in their lifestyle?
Yes, that is something I would love to talk more about. That's a really hard one because you're working. I'm so glad you're doing that work and you're asking that question. You're dealing with a really vulnerable population who are exposed to so much more on social media than certainly I was. I mean, social media wasn't, or the internet was a thing when I was growing up. And we thought things were bad back then, but it's far, far worse now. So that's a really vulnerable group. There's quite a lot of resources available. In fact, if the person who asked that question could maybe email me, I would love to send them some resources and some little cards that they could give out and maybe give some more advice. My email was on the first slide of the lecture, but yeah, if that person, I'd love to hear from them.
Now, I noticed you did your PhD on Maori and Pacific foods. Have you got any comments about Maori and Pacific patients in particular?
Yeah, so my PhD was on infants. So yeah, it was very specific, 7 to 10 month old infants and complementary feeding and iron status, which I realize is very different from what everyone's come to hear about today. But yeah, it's certainly, we were really keen to explore traditional foods, but I think because people who are Māori and Pacifica, particularly Pacifica, potentially see what we as white people might see as traditional foods as just normal foods. They didn't necessarily report them as such. But I think it's a particularly tricky area because certainly a few years ago and even decades ago, often research around Māori and Pacifica was very weight-centric and weight-focused, and it just seems to be the go-to for everyone is to talk about weight when it comes to Māori and Pacifica, and I think that's really, really harmful. I think the non-diet approach that I've been talking about, particularly with intuitive eating, like honouring your hunger, mindfulness with your eating, really listening to your body, that is, I guess, from a spiritual perspective, ties in a lot more with some more cultural beliefs and traditions around food and eating as well. But it's really tough. I think often there's a lot of deficit framing when it comes to Māori and Pacifica, and I think we need to see a lot more strengths-based framing with that. And I think certainly when I used to work at Waitemata, we would do what we called eating for your health groups. Possibly not the best name, but it did. But those groups would be very much focused on intuitive eating, the non-diet approach. And our Māori and Pacifica patients who came to them really resonated with it and really enjoyed it. So I think there's a lot of scope there for future research, looking at this approach with our Māori and Pacifica patients.
Right. So question here, what is your take on paleo diets?
That's really interesting. So in Paleolithic times, fiber almost solely came from fruit and vegetables, not grains. And what that meant is that there was a high ratio of soluble fiber to insoluble fiber, whereas with the Industrial Revolution and modern period, there's a lot more, I guess, a higher ratio typically of insoluble to soluble fiber. And soluble fiber is, as I'm sure everyone is well aware, incredibly important for things like lowering cholesterol, promoting satiety, promoting really good laxation, just the way it binds your bile salts and helps you excrete them, so your liver's taking more cholesterol to form more bile. So soluble fiber, I think that's the aspect of the paleo diet that I think is amazing and we should be doing more of. But in terms of the popularized paleo diet, popularized by Paleo Pete, I think he's called, the chef, I'm not so sure about that. And the thing is, there's a lot we also didn't know about Paleolithic times. Like people died because of childbirth, because of accidents, because of infectious diseases, like they get cut on their leg and that they'll die. So life expectancy was around 35 years in Paleolithic times. So it's really hard to know what the longer term effects of that diet is, but that particular aspect of it, with getting most of your fiber from fruits and vegetables and that soluble fiber, I think there's a lot behind that.
A comment here about, what do you think about weighing your food?
I don't think that's helpful, and that completely that really goes against everything that I've just talked about in terms of the non-diet approach. It's not about it. It's very much just another dieting behavior. So it's not relying on your stomach to tell you when you've had enough. It's relying on what's in front of you. And some people may have heard of this. There was a really interesting study done. In fact, there was a couple, but one that I was quite taken with was people were invited to trial a new type of soup, and they said, we want to get your opinion on the soup. We want to know, do you like it? What's the texture like, etc. So they were invited in, and they had these sort of big tables set up with long tablecloths, but half of the soup bowls had a keg underneath and little pipes going up into the bottom of the soup bowl, and they were very gradually refilling. And they found that people with the refilling soup bowl ate significantly more than the people who had the normal soup bowl that wasn't refilling. And it kind of shows that people tend to maybe rely on what's in front of them to know when to stop eating and know when to start eating, rather than how their stomach feels. And a really big part of the non-diet approach is tuning in to your hunger and satiety signal. So thinking about when you're a baby, or if you have a baby, if anyone's fed a baby, like a 7-month-old baby, you could have melted ice cream or chocolate on that spoon. If that baby's had enough, they're going to be turning their face away, sticking their tongue out, spitting it at you if you're really unlucky. But that's because the baby knows they've had enough, and we're born with this inbuilt ability to perfectly regulate our energy intake, and we lose it with the best of intentions if we are told that we must finish everything that's on our plate before we can have dessert, or there are starving children in Africa, or here you stubbed your toe, have a sausage, or whatever the treat might be in your house. we learn to ignore those satiety signals. So by weighing your food, you're just sort of feeding into that a little bit more, rather than sort of bringing it back and thinking, well, actually, how hungry am I right now? And eating slowly and really savoring your food and paying attention to when you're satisfied.
I think the term for that is learning to eat mindfully, isn't it? Mindful eating. I think you alluded to it before. A couple of questions there on intermittent fasting or timed eating.
Yep. So there's some more research around, I think I might get this wrong, so I apologize. I think it's called chronotyping and eating. Again, anything that's discouraging you from listening to your internal cues about when you're hungry and when you're full is not going to be helpful or sustainable long term.
So a question here from Rachel on cholesterol. One of the things I'm aware of is that everybody in New Zealand, if your average cholesterol is 5.8, if you're Japanese, well, that's high. You know, their average cholesterol is 3.5. I mean, we tend to reach for the statins here and we get them down to Japanese things. But I've had patients get down to Japanese cholesterols by avoiding dairy, interestingly. I had one patient who was a GP, and I thought he was prescribing himself a statin, actually. It was so dramatic. It went from 5.8 to 3.5, and I'm going, holy cow. And then a year later, it went back. He just couldn't hack a zero, no cheese, no milk, no yogurt. He went back and it bounced right back up to 5.7. Any thoughts on what we should be doing about cholesterol with nutrition?
Yeah, so for sure, dairy can have quite high levels of saturated fat, particularly depending on what type of dairy you're eating. So if you were to swap out your dairy for an alternative like soy or oat or almond, whatever, you're naturally going to be really reducing how much saturated fat you're getting. I think it's got to be something, I guess, again, coming back to the point of tonight's talk and the non-diet approach, it would be really important that it's something that feels sustainable and okay and not like it's going to make you feel deprived. I think, like for me, I would miss cheese too much. But again, I think if you really enjoy something, like if you really enjoy a beautiful brie or something like that, if you eat it really mindfully and you have it with other things, it can help mitigate that factor a little bit. I do agree, though, that we should be focusing on dietary modifications to lower cholesterol rather than statins, for sure. But yeah, milk is high in saturated fat. Red meat is high in saturated fat. I think in New Zealand, we do tend to have quite a heavy diet in those two things, and naturally, high in saturated fat.
A comment here about no dairy will due to calcium intake and daily requirements. So taking calcium tablets isn't recommended, is it?
No, I would feel very uneasy about calcium supplements, especially after that study at the University of Auckland a few years ago.
But Ian Reid in his group, wasn't it?
Yeah. So these days, it wasn't the case that long ago, but these days, almost all milk alternatives are really well fortified with calcium. So cow's milk has 120 milligrams of calcium per 100 mils of milk. So that's what you're looking for on the label to make sure that it's adequate. And there's some oat milk brands that don't quite hit the mark but aren't too far off. But calcium, you can also get that from a lot of other sources as well. You can buy like sardines or salmon with the little soft bones in the tin. Have that. It's a great source of calcium, for example. There's a little bit of calcium in things like nuts. There's quite a bit of calcium in soy as well, like tofu, for example. So you can get your calcium requirements. You just have to pay a bit of attention to what you're doing.
Leafy greens are high in calcium. Okay, thank you. What did that calcium supplement study a few years ago show? Well, I think when they took the tablets, they had more heart attacks. Well, I think it was a systematic review they did that pulled them all together, because I think each study wasn't big enough, because heart attacks are fairly rare.
The issue with that study was as well, I don't think there was a lot of control about what dietary calcium the participants were getting in. And so some of them were having massive rates of like huge amounts of calcium intake, like 3,000, 4,000 milligrams kind of level. And then some of them have pre-existing cardiovascular disease or atherosclerosis as well. So, and it kind of, yeah, it's enough, like as dietitians, we can prescribe, and I can tell you I would never prescribe a calcium supplement. It scares me too much after that.
How am I to improve my patient's long-term health outcomes without addressing weight, diet, and exercise directly?
You can address diet and exercise. That's the whole point, but you don't need to address weight per se. You can address the other two without the weight, which is often the stigmatizing factor for so many people.
Okay, if weight loss has such a bad long-term track record, why are we taught that 5 to 10% weight loss reduces risk of diabetes, hypertension, etc.?
I mean, it does. That's not wrong. But the fact is, there is that track record. So it is correct. It will reduce the risk, but other things can reduce the risk as well. And when you consider that long-term ability to sustain weight loss is so incredibly low, why focus on that? Why not focus on like fiber and exercise? There was a recent study showing that the main problems with diabetes in New Zealand is lack of fiber and lack of exercise, and weight was actually further down the list. So there's other things that can be focused on, but it's correct. It's just the likelihood of being able to keep, sustain it's not good.
Any tips when discussing with parents, caregivers about their Tamariki's weight?
My gut response is to maybe not, unless we're talking about underweight or failure to thrive, that faltering growth, that kind of thing. This is an issue that comes up, and I think with Plunkett, or I think they might be called something different now, it's talked about as young as 2, and it's certainly talked about at the before school check as well, and it's based off the growth charts. But my question would be is, what do you want to achieve by talking about it? So are you wanting to ensure that this child has like a really healthy, well-balanced diet, in which case you could focus just on that rather than on their body size? Because as we all know, children hear everything and pick up everything, and when they pick that up, they can take that on board, and we are seeing that higher incidence of disordered eating and weight concern in young children.
Lovely. What's the difference between a dietitian and a nutritionist? I must admit, I'm not. I always tread carefully with that one.
Yeah, for sure. So, a dietitian is a protected term in New Zealand. So if you're a registered dietitian, you're a registered healthcare professional, much like a physiotherapist or a nurse or whatever. Anyone can call themselves a nutritionist. However, registered nutritionist is protected as well. So if you have an undergraduate degree in science that majors in human nutrition, you can then go and register as a nutritionist. You're under supervision for at least your first year, I think. And there's you're bound by evidence-based practice, that kind of thing. So a nutritionist is more likely, a nutritionist can't work in a hospital. A nutritionist won't do tube feeds, for example, whereas a dietitian would do those things and would work in a hospital. I hope that kind of clarifies it. Dietitian is a protected term, so you cannot call yourself a dietitian unless you have done, so dietitian is a 3-year undergrad degree, then a 2-year master's degree with registration with ongoing competencies. And a registered nutrition is either can be a master's in human nutrition, for example, which many have, or a PhD for that matter, or it can be an undergraduate degree, and then you are registered with the Nutrition Association. And my advice is that you want to specifically be looking for the word registered nutritionist if you're referring to nutritionist, or dietitian is fine.
So just one last question here, because we're at 8:45. Have you found any apps that have been helpful for patients?
Oh.
Or websites? Somebody put a website.
I have found no is the short answer, I'm afraid, because apps all seem to be weight focused, but I found a ton of amazing Instagram accounts to follow, which are done by academics, dietitians, registered nutritionists, fitness professionals who
Can you give us one name, maybe? We'll put it.
Oh my gosh, that feels like a lot of pressure.
Okay. No.
The Fat Doctor.
I'd just like to thank you, Maria. It's been a delightful evening. So lovely. Well, thank you very much, and look forward to further contact.
Thank you so much.